So my talk here today is decreased wave reflection but increased aortic blood pressure during aerobic exercise, a paradox to ponder. So my goal here today is to have you equipped to answer these 4 questions. 1, what is aortic blood pressure and its clinical relevance? 2, what factors influence aortic blood pressure? 3, how does aerobic exercise affect aortic blood pressure and wave reflections in young adults? And then lastly, is the effect of aerobic exercise on aortic blood pressure and wave reflection consistent with healthy aging? So let's get started here at the first. We're typically used to seeing blood pressure expressed as systolic over diastolic. In this case here, we see 120 over 50, and this being in the brachial artery. However, blood pressure is actually a measure over time. So on the y-axis, we have blood pressure, and the x-axis, we have time. You can see a tracing there of the brachial artery. Systolic blood pressure varies greatly throughout the arterial tree, so much so that at the aorta, it's lower than it is at the brachial artery. And this difference is actually varies greatly between individuals. So for example, we have a patient 1 and patient 2. Here, patient 1 in red, patient 2 in blue. As you can see, their brachial blood pressure is the same of 144 over 90. However, when looking at their aortic or central blood pressure, I'll use this interchangeably today, you can see here that patient 1 has a blood pressure of 136 over 90, but patient 2's blood pressure is 122 over 90. So why is this important? Well, multiple studies have shown that central blood pressure is more strongly related to cardiovascular disease and outcomes compared to brachial blood pressure. Next question to ask here is, okay, what influences aortic blood pressure? Hopefully this works here. All right. So when the left ventricle ejects a stroke volume, it propagates along the arterial tree as a forward-going pressure wave, shown here in orange. When this pressure wave reaches reflection sites, such as bifurcations, vascular beds, and sites of mismatch impedance, a percentage of it is reflected back toward the heart. When this reflected wave returns to the heart during diastole, it's beneficial in aiding in coronary perfusion. However, whenever it returns to the heart during systole, it can augment mid to late systolic load. Shown here is a backward wave in blue converging with a forward wave. When these two converge, they make up overall central blood pressure. You can see here, a little difficult, but in the dark gray is a tracing of the central blood pressure. And again, in the orange, forward wave, and the blue, backward wave. The earlier that backward wave returns and the larger that backward wave is, the more aortic blood pressure will increase. And you can appreciate that by those bumps in pressure. Let's see if this works. That's right. These bumps in pressure here. So this augmented mid to late systolic load increases or can cause left ventricular hypertrophy, myocardial fibrosis, and contractile dysfunction, ultimately leading to a vicious positive feedback cycle that can prelude in favor of the development of cardiovascular disease such as heart failure. So how are these waves acquired? One way we can do this is with applanation tonometry. As depicted here in the upper left-hand corner is a wristband tonometer. So how this works is a tonometer or pressure sensor compresses or applanates the desired artery against bone, whereby when the pulse passes through this area, it traces pressure over time. From here, the peripheral blood pressure undergoes a generalized transfer function to get a central or aortic pressure wave, shown here. These aortic pressure waves are useful, and you can derive surrogate measures of wave reflections from these. For today, we'll focus on augmentation index, and just to define what that is, it's augmented pressure, which is our second shoulder of systolic peak minus the first shoulder of systolic peak. And augmented pressure is relative to central pulse pressure. When you do these, you get a percentage known as our augmentation index. And this is predictive, or this can be used for predictive of cardiovascular events and mortality. So although these measures are quick and easy to use, they do come with a few drawbacks. Those being age, left ventricular contractility, pulse pressure, and heart rate. For example, with heart rate, we can see here with an increase in heart rate, augmentation index actually decreases. And this is in a study where they just electrically pace the heart with all their factors being constant. You can appreciate this The little red dots here, there's a positive augmentation at 60 beats per minute. And you can see here as heart rate increases, the augmentation actually drops and becomes negative. Nevertheless, these are quick and easy to use, but they do, again, have some limitations. Particularly when you're doing these with exercise, it's hard to tell if the reduction augmentation index is from heart rate or other factors. So to look at this, some studies in the past, first one being from Sharman et al. In 2005, in panel A and C, you'll see here in a second. And panel B will be from Casey et al. 2008, and they'll be in panels B and D. But basically, they did seated cycle exercise at incremental intensities of heart rate max. And you can appreciate here that augmentation index incrementally decreased with increase in intensity of exercise. And that was the case here for both studies. So with this reduction augmentation index, we'd expect there to be lower central pressure. However, we actually see that central pressure, systolic, and pulse pressure increase in both of these studies. So if you like visuals better than just numbers on graphs and stuff, this is a little bit better representation of that. In the upper left-hand corner here, we have baseline, and then progressive intensity of exercise all the way to vigorous intensity. Just what I want you to appreciate here is that, we see systolic blood pressure increasing as intensity of exercise increases, but again, we get this reduction in augmentation index. And you can appreciate that with, again, this little bump in pressure here becomes minimal, and then eventually is negative. So this warrants a question: what caused the increase in aortic blood pressure? To answer this question, we use wave separation analysis, which uses central pressure with also aortic flow to decompose central pressure into forward and backward components. This allows us to independently assess the amplitude and timing. So I'll orient you to this figure here. Again, on the y-axis we have pressure, x we have time. This black tracing here is that aortic pressure wave we've seen before. In blue is a forward pressure wave amplitude, whereby we gather its maximal amplitude. In red is a backward pressure wave, again, where we gather its maximal amplitude. When these two are expressed relative to one another, that's reflection magnitude. And then reflected wave transit time is a time delay between zero pressure crossing of forward and backward waves. Recently, our lab used this method of analysis to assess wave reflections during exercise. Also, we sought to answer the question, do any of these components influence aortic blood pressure? So just to orient you to these graphs ahead in our studies, we have baseline, light, moderate, and vigorous intensity exercise. The light, moderate, and vigorous correspond with 40, 50, and 60% of heart rate max. And this was done in recumbent cycle exercise. First here in this graph, we see that forward pressure wave amplitude incrementally increased with increasing intensity of exercise. And for those that like a visual representation of this, this is from one of our subjects here. You can appreciate at baseline, we're at 25 millimeters of mercury, and you can see it increases to 35 millimeters of mercury during vigorous intensity. So what's maybe causing this increase in forward pressure wave? We suggest it is because of an increase in left ventricular contractility, as well as an increase in stroke volume. Many studies have shown, right, with aerobic exercise, you get an increase in cardiac output with heart rate and the ejection, and we're suggesting that that is the cause of this increased forward pressure wave. Now on to the backward pressure wave. In this study here, we saw that it actually decreased with our incremental intensity exercise. Again, a visual representation for those that like this. It's relatively low at baseline of 12 millimeters of mercury, and again, you can see with the increase in intensity of exercise, it drops in the case of this subject to 7 millimeters of mercury at vigorous intensity. Again, same question we can ask, what's causing this? So first, I want to point out this figure here from Lee et al., and I believe it's in 2016, where they used arterial modeling to represent that there's a direct and linear relation between forward pressure wave amplitude and backward pressure wave amplitude, so that as forward pressure wave is increasing, there's an increase in backward pressure wave. Again, this is at baseline though, and in our study, we didn't exactly see this relation occurring. we saw that there is, again, a reduction in that backward pressure wave despite an increase in forward. So what is causing this? We suggest this is due to vasodilation of the vascular beds that are exercising. And this vasodilation is causing a reduction in systemic vascular resistance, specifically in these exercising beds. Numerous pharmacological studies have shown that wave reflection can be reduced by giving vasodilators, for example, like nitroglycerin or something like that, or pharmacological agents as such. So as a reminder, reflection magnitude is backward pressure wave amplitude relative to forward pressure wave amplitude. So that ratio we saw with this study, that it incrementally decreased with the increasing intensity of exercise. Again, for a visual representation of that, we have here at baseline for our healthy young adults, about 48% is the reflection magnitude, and we see that decreases with the exercise. Instead of vigorous intensity, it is at 20%. So on to the timing component of wave reflection. So that's wave reflection transit time. We see here in the figure on the right that reflected wave transit time, it decreased with the increasing intensity of exercise. We also corrected this for heart rate, normalizing it for ejection duration because, as you'd expect with exercise, right, heart rate goes up, ejection duration is shortened. And we still found when correcting it for this that the reflected wave returned earlier. Furthermore, again, this data not shown here, but we corrected it for change in mean arterial pressure because the speed in which the pulse travels can be greatly dependent on pressure in the arteries. And at some of the intensities, we found that when we covariated for mean arterial pressure, this change was not significant. So to answer our question we posed at the beginning, what's influencing aortic blood pressure then? So using a stepwise multiple linear regression to predict change in aortic pulse pressure, we used the predictors forward pressure wave, change in backward pressure wave, and change in reflected wave transit time. In this stepwise multiple linear regression, we only kept the predictors that were significant. We found that an increase in forward pressure wave, but not backward or timing, predicted the increase in aortic blood pressure. So much so that the change in forward pressure wave accounted for 60% of the variability in aortic pulse pressure during exercise. So just to wrap up here with our young, healthy adults, we saw that with aerobic exercise, there was an increase in aortic blood pressure, an increase in forward pressure wave amplitude, an increase in backward pressure wave amplitude, and again, these two coupled for the reduction in reflection magnitude. And then lastly, we saw that reflected wave transit time decreased, again, even when corrected for ejection duration, but that there might be an influence of change in mean arterial pressure at some of the intensities. The increase in aortic blood pressure during aerobic exercise was driven by the increase in forward pressure, not wave reflections. So just a quick summary of everything with the young adults here. We can say that the pressure wave response during aerobic exercise appears to limit the impact of wave reflections on the left ventricle, thereby optimizing central hemodynamics. So I mentioned this is one of our first studies looking at this. Next from here, we asked the question, okay, we found this in young adults. What's going on in the case of healthy aging? So just to orient you to central hemodynamics in healthy aging, on the left-hand side here is a compliant aorta representing a young, healthy adult, where they have low arterial stiffness denoted by a slower pulse wave velocity. They have a lower forward and backward pressure wave amplitude, and there's a later reflection or later return of wave reflection. So it's minimally augmenting systolic pressure. However, with healthy aging, the arteries become stiffer. So we have an increased pulse wave velocity, again denoting that increased arterial stiffness. We have a higher forward pressure wave amplitude as well as backward pressure wave amplitude, and an earlier return of that wave reflection. So now there's more of a pronounced augmentation in central pressure in these older adults. So a question we asked, again, with this profile of older adults and their central hemodynamics, what's going on with aerobic exercise? Do they see the same effect as young, healthy adults see, or is there some sort of attenuated response? So with this study here, just to orient you to the figures ahead, In the white open circles, we have young adults. In the gray filled in circles, we'll have our older adults. Young adults in this study here were from 18 to 40, and the older adults were from 60 to 80. On the left-hand side here, we see that there was a reduction in reflection magnitude. Again, similar to our first study here, we see that there was a reduction with the increase in intensity of exercise. And then when we compared that change in reflection magnitude relative to respective baselines for young and older adults, we see here actually that there was a greater reduction in reflection magnitude in the older adults as compared to the young adults, and this being at the light and the moderate intensities of exercise. I think I failed to mention, but the intensities of exercise here, again, light, moderate, and vigorous, were 40, 60, and 80% heart rate max, and this is done on a supine cycle. Because reflection magnitude is dependent on the forward and backward pressure wave components, we took a look at what's going on with each one of those and comparing young and older adults. In panel A, we can see here that the change in forward pressure wave amplitude relative to baseline was similarly increased in older adults. There was just a minimally higher change in forward pressure wave amplitude in the young adults compared to the older adults at moderate intensity. However, now when looking at the backward pressure wave amplitude, we see that there's a more negative change in the older adults. So what I mean by that is we can see here the delta in the older adults, it's lower than compared to the younger adults. And that being for light and moderate intensity exercise. And lastly here, looking at the timing component, so that reflected wave transit time. Similar to the first study displayed here, we see that there's a reduction in reflected wave transit time, so denoting that reflected wave returns earlier in both young and older adults. However, when we compare this response compared to baseline in the young and older adults, we see here that reflected wave transit time, the reduction in it was attenuated in the older adults. Some possible reasons this may be is you can appreciate, again, older adults here, this is their baseline. Younger adults, this is their baseline. It's a lot lower in the older adults at baseline, so there might be some sort of floor effect happening here where it can't decrease any further in the older adults. So, same thing as in the first study, we asked the question, okay, what's influencing the change in aortic pulse pressure in the young and in the older adults? Are there any differences with that? So again, using a stepwise multiple linear regression to predict the change in aortic pulse pressure during exercise, we use the predictors change in forward pressure, change in backward pressure amplitude, and change in reflected wave transit time. Similar to the first study, in young adults, the forward pressure wave amplitude, the change in that predicted the change in aortic pulse pressure. But in the older adults, differently, we saw that the increase in backward pressure wave and forward pressure wave, as well as an earlier return of wave reflection, all contributed to the model showing that these caused an increase in aortic pulse pressure. So some concluding remarks with the older adults. One, despite older adults having a more deleterious wave reflection profile at rest, they seem to have a greater reduction in reflection magnitude, but an attenuated reduction in reflected wave transit time during aerobic exercise. This response may be favorable in minimizing excess pressure and work on the left ventricle during exercise for older adults. And lastly, the change in wave reflection appears to influence the change in aortic pulse pressure in older, but not in younger adults during aerobic exercise. Just to finish up here, some future directions for this line of work. The one direction could be some mechanistic studies to help elucidate the role of vasodilation and vasoconstriction on wave reflection magnitude and timing. I mentioned earlier there are some pharmacological studies that did this, but a lot of these were done with surrogate measures, so it'd be good to see some of these done with more comprehensive measures. Second, to explore the clinical significance of changes in wave reflection during exercise and see if those are potentially correlated or predictive of cardiovascular disease outcomes. And then lastly, it'd be good to see a shift in the field from these surrogate measures more to these more comprehensive measures, again, to independently assess the magnitude and timing components. Right. I'd just like to thank MARC-ACSM for having us here today. The two labs I'm a part of, Dr. Julio Chirinos at UPenn, he's very helpful with a lot of the analysis of this, and the funding sources listed here. Thank you.
The talk I'm going to have is focused on what happens after exercise. So Joe just talked us through what's going on during exercise, and I'm going to follow up with what's going on in that all-important recovery period afterwards. So here's my outline. I'm going to talk about what we know about changes in blood pressure and vascular conductance after exercise, how that may potentially influence pulse wave reflections, and some recent findings from our lab, and then briefly touch on some future directions that we're working on currently. So post-exercise decreases in blood pressure were first noted in 1898. As you can read here at the bottom, Leonard Hill ran 400 yards and then measured his blood pressure, among other things, and wrote that the arterial pressure becomes more depressed below the normal resting pressure after severe muscular work. And a lot of the other studies around this time had similar findings. And then there was a jogging craze in the 70s and 80s, and kind of brought this post-exercise hypotension topic back to the forefront. So this was a personal letter written to the British Medical Journal. And this gentleman was diagnosed with hypertension when he was a PhD student, and then when he was a postdoc, he took his blood pressure 7,000 times over 3 years, and noted that after exercise, his blood pressure was lower. And he used this to kind of game the system when he went to the doctor. He said 25 or more minutes after sustained exercise, after 25 or more minutes of sustained exercise, he saw a reduction in blood pressure that lasted from 4 to 10 hours after exercise. So this spurred a bunch more of these post-exercise hypotension studies during the 80s. This is one of them. Hagberg and colleagues in the late 80s looked at hypertensive individuals, and they had them do 3 bouts of 15 minutes at 70% of VO2 max. And as you can see here on the y-axis, we have the change in blood pressure, and on the x-axis, we have time after exercise. You'll notice that the systolic blood pressure was markedly reduced following exercise for up to 2 hours after exercise, and actually maybe even beyond that in some individuals. Diastolic pressure was also lower, up to about 75 minutes after exercise. And so the question is then, does this occur in normotensive individuals, and what are the mechanisms? So this study by Coates and colleagues looked at normotensive individuals. They had them do like this prolonged max exercise test that lasted 15 to 45 minutes depending on the subject. In the black line, you can see that systolic blood pressure was increased shortly after exercise, and then it slowly declined for the next hour. Whereas the control day, which was the dashed line, there was no change. The diastolic blood pressure was low after exercise and stayed low for the following hour. So they measured cardiac output using echo, and they found that cardiac output was elevated the entire hour after exercise during the exercise condition, where there was no change on the control day, obviously. Which meant that systemic vascular resistance here, this is represented as a percent of baseline change, systemic vascular resistance was significantly lower for the entire hour following exercise. So Dr. Hollowell at the University of Oregon has done a lot of work in this area over the last 2.5 decades. This is one paper that shows leg vascular conductance. So conductance is kind of the inverse, or it is the inverse of resistance. So it's blood flow over blood pressure. So any change in conductance signifies a change in vasodilation or vasoconstriction. So an increase in conductance equals vasodilation. And as you can see here, after exercise, conductance was about 2 to 3 times higher, and it stayed elevated for about 100 minutes after exercise. So then what's the mechanism for this sustained vasodilation? About 10 years prior to that study, Dr. Hallowell looked at sympathetic nerve activity. And so just like all the other studies that I've shown so far, an hour of moderate intensity exercise caused a reduction in systolic blood pressure and mean arterial pressure. They didn't see a reduction in diastolic blood pressure, but this was measured 90 minutes out. They also saw a reduction in calf vascular resistance, so suggested of vasodilation occurring in the calf. When you look at muscle sympathetic nerve activity, here it's shown as bursts per minute. They saw a reduction in the post-exercise, so 90 minutes after exercise, muscle sympathetic nerve activity was lower. And that was true whether you represented it as burst per minute, burst per 100 heartbeats, total activity, any way you can measure sympathetic nerve activity, it was lower. So that suggests that maybe this sustained vasodilation is just a lack of vasoconstriction, right? We know that the baroreceptor should sense that lower blood pressure after exercise and cause an increase in MSNA, cause the blood vessels to constrict, and we're not seeing that. However, Dr. Hollowell's lab hypothesized that maybe it's more than just a lack of vasoconstriction, maybe there's active vasodilation. And so they worked through multiple different vasodilatory pathways by blocking them and seeing what changed after exercise. After blocking nitric oxide, cyclooxygenase, a few others, they saw no results, but then they tried histamine. So histamines are vasodilators. When you give an antihistamine, they show that you reduce the femoral vascular conductance, shown here on the y-axis, for the entire 90 minutes after exercise. And it's both an H1 receptor antagonist does this and an H2 receptor. So the H1 receptor is Allegra, and the H2 receptor, I believe, is Zantac. So that brings me to wave reflection, the title of my talk. When we talk about wave reflection, a lot of people immediately think about aortic stiffness, as Joe alluded to in his last study there. However, it's important to remember that the reflected waves originate from all the bifurcations in the vascular tree. And we know that the most bifurcations occur distally in the muscle beds themselves, where you have the microcirculation. There are innumerable bifurcations and changes in impedance of the blood vessel, which would cause the wave reflections. And so this is the area where sympathetic nerve activity causes vasoconstriction, and also local vasodilatory factors cause vasodilation. So it would make sense that we could hypothesize that we would see reduced wave reflections during this time period, or after exercise when we see dilations in these vascular beds. So as Joe highlighted in his talk, augmentation index is a way that a lot of people look at wave reflection. It's a surrogate marker, and as he discussed, there are some shortcomings with it. This is a meta-analysis that was published in 2018 showing augmentation index after exercise. This was the aerobic exercise. They also looked at resistance. But after aerobic exercise, augmentation index was decreased. That would suggest that wave reflections have decreased during this time period. Interestingly, though, when you normalize that augmentation index to a standard heart rate of 75 beats per minute, as sometimes people do to overcome that one of the limitations of augmentation index, they actually see an increase in augmentation index, signified here by this guy there. So at this point, it's kind of still up in the air. There have been a few studies that have used non-surrogate measures of pulse wave reflection. Joe mentioned how to do wave separation analysis, you need a flow wave and a pressure wave. These studies importantly used kind of a synthetic pressure wave, so there are some limitations with that, but this gives us a good estimate of what happened. So the backward pressure wave after exercise, so this was 15 minutes after exercise in middle-aged hypertensives. and they did 50 minutes of moderate intensity exercise. Backward pressure wave was reduced at that 15-minute time point. However, they did not continue tracking any longer after that. This paper here was young individuals who performed a VO2 max test, and they were tracked for a full 30 minutes. And so just like the previous paper, you see that the backward pressure wave amplitude was reduced 15 and now 30 minutes after exercise. However, they stopped at 30 when it was still clearly lower. So we identified some key weaknesses in the literature currently. So for one, there's a reliance on surrogate measures. And this is because, measuring flow out of the ventricle, takes a good quality ultrasound, takes some skill. So it's understandable that a lot of people rely on augmentation index. Post-exercise monitoring has also been limited to less than an hour. All of those studies, even that use augmentation index, stopped at the 1 hour time point. However, as I showed earlier, the post-exercise hypotension lasts 2 to 10 hours, even if you look at the one guy that studied himself. So we want to know, do these changes in wave reflection parallel post-exercise hypotension? And then last but not least, a lot of these studies used maximal exercise, which is great, but does that really represent what people actually do when they exercise? So we recently published a study where we looked at pulse wave reflections after moderate intensity aerobic exercise, much similar to what most of us probably do. So we had 14 young normotensive individuals across a pretty wide spread of aerobic fitness levels. So I think our VO2 peaks ranged from 28 to 72. We measured hemodynamics at baseline, had them exercise at 60% of VO2 max for 60 minutes, and then we measured their hemodynamics every 20 minutes for the 2 hours after exercise. So this figure shows the aortic blood pressure, so the change in aortic systolic and diastolic blood pressure. And as you can see, both figures show that after exercise, both systolic and diastolic blood pressures are reduced, just as we would expect from all of the previous studies that I've highlighted. So it's good that we were able to repeat that. Then we also had the post-exercise hemodynamic changes that we'd expect in more of the standard measures of hemodynamics. First, on the left side, we have heart rate, and as you can see, heart rate was elevated for 40 minutes after exercise, and then it came back down to baseline. On the right panel, we have stroke volume, and there was no change in stroke volume across the entire recovery period. So stroke volume times cardiac output, you see that there was really no change in cardiac output. It was trending towards a change, but overall there was not a change. On the right side, I have total peripheral resistance or systemic vascular resistance, and we saw a lower systemic vascular resistance for the first hour after exercise. So similar to the other studies. So now I'll explain how we derive the wave reflection measures. So we use pressure flow analysis. So this figure on the left is from one of our subjects. This is a tracing of their aortic outflow velocity. We get 10 of them and average them, that is what we have in the figure to the right. And then at the same time, we're at the wrist doing radial tonometry, as Joe explained in his talk, where we can apply a generalized transfer function and get a aortic blood pressure wave. And as you can see here, we then line up the two waves, the flow in red and the pressure in blue, and time align them, and then we can, at that point, separate the waves into forward and backward components. So we take that pressure wave, apply a little bit of math to it, and we get the two different waves, forward and backward. And then as highlighted earlier, we have a reflected wave travel time or reflected wave transit time, which is the time delay between the zero crossing of each wave. And then what I'm going to show in this next figure is the amplitude of that backward traveling reflected wave. And so here you see after exercise, we have the change in reflected wave on the y-axis, and you can see the amplitude is reduced for the entire 2-hour time period after exercise. So previous studies had shown up to 30 minutes. We show that that continues on for another 90 minutes, beyond that at least. We also have reflected wave travel time, and we see that it's actually extended, or it's increased or augmented about 60 to 100 minutes after exercise. So during that time period, the reflected wave is arriving at the left ventricle later. So as I mentioned before, we often think of changes in wave reflections as having to do with aortic stiffness. We only measured our carotid femoral pulse wave velocity, which is an index of aortic stiffness. We only measured it at baseline at 60 minutes, and we saw no change. However, that's unsurprising. This is that meta-analysis I referred to earlier. And all of these studies, when put together, they showed zero change in carotid femoral pulse wave velocity, suggesting that aerobic exercise has really no effect in young, healthy individuals on aortic stiffness. And so this is a paper by Dr. Ranadiwe, and he might be in the audience today. And he showed, this was like 10 years ago now, he showed in his study, after a maximal exercise test, there was also no change in pulse wave velocity, but they took it a step further and measured lower limb pulse wave velocity. And as Joe highlighted earlier, as we move distally away from the heart, we have an increase in pressure. The blood vessels go from elastic arteries to muscular arteries. They're stiffer, and that is why we see a faster pulse wave velocity in the lower limb. However, after exercise, that pulse wave velocity is decreased. So what we think is happening that explains at least our reflected wave transit time data is we think that at baseline, the aorta has a relatively low pulse wave velocity in our young, healthy individuals. And then as you move distally, you get an increase in the velocity of that wave, increase in stiffness. After exercise, it appears as though we're probably having a decrease in that pulse wave velocity in the periphery, which is then slowing the speed at which the forward and reflected waves travel away from and back to the heart. So why does this matter? What is the benefit of changing wave reflection? And so Dr. Stock showed this figure in his talk. When that reflected wave arrives during systole, especially mid to late systole, you get an increased load on the heart while the heart muscle is actually shortening or already shortening, which is, as we know from muscle physiology classes, when the muscle is already short, it's kind of weak. And that suggests that, or that causes an increased load, which then can cause left ventricular hypertrophy, concentric remodeling, contractile dysfunction, and myocardial fibrosis. So we have a metric to actually quantify this mid to late systolic load, and we call it wasted pressure effort. And that is basically the amount of work the heart is having to do due to the reflected waves. And so that is shown here in the red. The gray is the amount of work the heart would have to do if there were no wave reflections. So here is an example from our data. This is one subject at baseline and 80 minutes. You'll note that the scale is slightly different on the 80 minutes, so it's actually, the peak blood pressure is actually lower. And when you put that together, the wasted pressure effort, the red area, is smaller in the post-exercise, 80-minute post-exercise condition than the baseline. And so when we look at our data as a whole, we see that this wasted pressure effort is reduced from 40 to 100 minutes after exercise, suggesting that during that time period, the heart is having to work less hard to pump blood. And so then we wanted to determine what were the causes of this. And we did stepwise linear regression, stepwise multiple linear regression, and we found that both the change in reflected wave transit time and the change in backward wave amplitude were significant predictors of this change in wasted pressure effort, as you would expect. So in conclusion, vasodilation following moderate intensity aerobic exercise results in decreases in the amplitude of wave reflections and causes them to arrive later to the left ventricle. As a consequence, the left ventricle is required to generate less pressure and thus waste less effort. And these effects are maintained for about 100 minutes after exercise in young, healthy individuals. Whether that's true in different populations, we have not yet tested. So some future directions our lab is aiming to do. We have a study that's been approved. I was hoping to present some data today, but ran out of time. We want to identify the level of the vascular tree that most influences the post-exercise changes. So like I alluded to earlier, we're thinking that that reflected wave travel time is probably due to the muscular arteries, like the femoral artery and so on, dilating and having lower pulse wave velocity, but we have not tested that experimentally. And then we also want to determine if changes in wave reflection and wasted pressure effort have any influence on cardiac mechanics. So we look forward to hopefully presenting that data in the near future.
Thank you very much for the introduction, and thank you guys all for coming and staying for the talks. I know I'm the last one, so it's always hit or miss how many people I'll stay throughout the whole thing, but thank you for being here. So a brief outline for what I'm going to talk about today. I'm going to give some brief background on what is aortic blood pressure and wave reflections. I know Joe and Jordan did a great job of that, but I just want to bring everyone back to some of the background on that. I'm going to talk briefly about some of the literature on how does exercise impact aortic blood pressure and wave reflections. And then I'm going to get into what do we know about sex differences in wave reflections and aortic blood pressure, and specifically focus on this window of sex differences post-exercise and how are the different sexes regulating blood pressure following exercise. And then ultimately try to answer the question, does sex matter when we look at blood pressure regulation and exercise trained individuals? So we all know that blood pressure has long been a modifiable risk factor that has been predictive of the development of cardiovascular disease and end target organ damage. And so a lot of us in the room really try to come up with treatments and interventions to try to mitigate that risk through reducing blood pressure long term. Classically, we measure blood pressure with the brachial artery. So we place the blood pressure cuff on the brachial artery, and we get a measurement ideally around 120/80. However, recent research has really shown and pushed that the central aortic pressure is really more representative of cardiovascular risk and long-term progression of disease. And for that reason, there's been numerous non-invasive techniques that have been spoken about in previous sessions where we can actually estimate and calculate aortic blood pressure, and that more accurately represents someone's risk for cardiovascular disease. Specifically, we can use applanation tonometry, and there's also been numerous devices that have been on the market recently that can be placed over the brachial artery, use a generalized transfer function, and therefore estimate aortic blood pressure. So we see an animation here that's supposed to depict the fact that the left ventricle is ejecting blood as we're all sitting here in the room, right? As that left ventricular ejects blood, a blood pressure waveform is formed. And so we have a forward traveling pressure wave that's going to come in contact with various bifurcations and areas of impedance throughout the arterial tree. And as that happens, some of that blood pressure is actually reflected back, and it's superimposed onto that forward wave, and it can augment pressure and create this aortic blood pressure wave that we see here. And as we see in various disease states or with age or in different populations, we see augmented pressure where we actually see this aortic blood pressure wave pictured here get steeper or narrower, and therefore we have increased aortic pressure. So as been spoken about throughout this session, we know that blood pressure, aortic blood pressure in specific, can be broken down into waves, right? Waveforms, forward wave and the reflected wave through a technique called wave separation analysis. So we get the forward wave in orange here and the backward wave in blue here. And the research has shown that the higher the reflected wave is and the sooner it arrives back and superimposes on that forward wave, we actually see that that increases aortic blood pressure, and that's a significant predictor of cardiac events alone. We all agree that aerobic exercise in general is going to be greatly beneficial for blood pressure and wave reflections. And in particular, blood pressure is significantly reduced upwards of 90 minutes following exercise. And this has been largely studied and due to that reduced total peripheral resistance, as is spoken about today, and it's the increased vasodilation that's really driving that post-exercise hypotension. Research has also shown that the decrease in blood pressure has also been tightly regulated by studying the wave reflection. So we can actually take apart that blood pressure and look at the magnitude and the velocity of the reflected pressure waves and what's actually really driving that blood pressure reduction. And so as Jordan highlighted on his work that he recently did, he examined wave reflections post-exercise in 14 relatively healthy individuals who cycled for prolonged exercise at moderate intensity for 60 minutes. And what he showed in the study was that there was a decreased wave reflection magnitude and a delayed return post-exercise, as well as reduced blood pressure for 120 minutes post-exercise. This was predominantly due to and accounted for by reductions in that forward wave pressure, and even though we did not see changes in cardiac output and stroke volume. The reflected wave pressure was also attenuated for upwards of 120 minutes post-exercise, and ultimately this is important because it's associated with reduced work that the left ventricle is doing in response to exercise. However, the question in the room is, does sex matter, right? So we noticed in Jordan's study, he did have an even split of genders, and not to put him on the spot, but given the situation of research in the last 2 years, we haven't really been able to answer this question of, does sex matter? And what we see in the background in the research, back in the 80s, we have established very long that females are at a lower risk for cardiovascular disease when compared to males in that premenopausal time period. And this has been shown where women have a lower blood pressure response, lower blood pressure at rest, both during and at peak exercise and following exercise. And this is obviously associated with a lower burden on the cardiovascular system. And so we see in these figures here, the women are in the white line bars on the top graph, and we see that throughout exercise duration and following exercise, their systolic blood pressure is significantly lower than men. And then we see below their aortic blood pressure in the straight line, not the dashed line. The straight line indicates the women are also at a significantly lower blood pressure, both at rest and throughout exercise. Research has asked, why is this happening? And we talk about the elephant in the room, right, of hormones. So most likely this is due to the presence of estrogen in premenopausal women. Estrogen is a very potent vasodilator, and that has been shown to lower blood pressure and lead to a more beneficial response in women compared to males. With regards to wave reflections, interestingly, at rest, women have larger reflected wave magnitudes than men. And this has been studied, and it's been a little bit controversial, but it's been shown that this might be due to the fact that we have a smaller stature and we're shorter, and therefore the reflective wave is going to come back sooner, and it's going to be higher in women than men. So we've also seen in larger studies that both age and sex are predictors of pressure due to wave reflection. So it's confirmed in a study by Mitchell, who showed that if you look at these graphs in the open circles, we see women, and the closed circles, we see men. And we see across all age categories from 50 to 70 years of age, a significant increase in, or steady increase in forward wave pressure across both genders. And interestingly, you'll see that at age 60, presumably when women are entered into menopause, we see a significant exponential increase in that forward wave pressure in women compared to men. When we look on the right, reflected wave pressure, we see that a steady increase in reflected pressure in both genders with a slight decrease in women at the age of 60. These sex differences in central hemodynamics also apply to trained populations. As a part of a larger study that I recently published looking at sex differences in cardiovascular adaptations in marathon runners, as part of that study, we also looked at resting hemodynamics, specifically central hemodynamics, aortic blood pressure, and wave reflections. And we did also find sex differences, whereby we saw that women had a lower wave reflections and aortic blood pressure, regardless of training status compared to males. So it's well established that you would agree that sex differences exist. We have women having lower blood pressure at rest, during exercise, and following exercise. But really, this post-exercise hypotension is an important response to look at, because if you are consistently undergoing repeated bouts of exercise and having a response to that exercise, that's going to be your chronic state. So therefore, inadequate blood pressure regulation is a risk factor for cardiac events. Acute aerobic and resistance exercise studies have shown that there is a sex difference in how blood pressure is regulated following exercise. So going back numerous years, 20 years ago, it was established that gender differences do exist in regards to that recovery period from exercise. So we see that women have a larger reduction in blood pressure compared to men, and this is also in line with decreased stroke volume, larger decreases in peripheral resistance, while males also have a reduction in blood pressure, but it doesn't appear to be due to overall total peripheral resistance only. In contrast, another study showed no sex difference in blood pressure reductions regardless of training status. So they looked at the influence of endurance exercise training, status, and gender on that post-exercise hypotension response. And they found that both men and women had the same blood pressure response. However, interestingly, women had significantly reduced total peripheral resistance, suggesting that both genders experience a reduction in blood pressure, but they might achieve this differently. Another study looking at acute resistance exercise more recently, so in 2013, this third study found sex differences in response to resistance exercise, where we see that men and women both had a reduction in blood pressure following exercise, again, which we'd expect. However, the determinants for that blood pressure were different. So we see that men reduced cardiac output, while women significantly reduced total peripheral resistance. So really it begs the question of where do we go from here? And that's where wave reflections come in. So wave separation analysis might allow us to look more closely at this to determine what is actually happening in the minutes after exercise that further affect these mechanistic changes and differences. So a study by Wee et al. In 2019 was really the first study to use wave separation analysis to examine sex differences in blood pressure regulation following maximal exercise. And so this is really an important study, right? Because now we're not just looking at, okay, we know that forward and reflected wave pressure reduce following exercise, but is that different amongst gender, and what's actually causing that? What's the result of that? So this study looked at a single bout of maximal cycling exercise. They examined sex differences in the waveform components, and they saw that females actually have increased wave reflections but regulate blood pressure differently post-exercise by reducing aortic blood pressure with a reduction in the reflected wave pressure. Men actually had a significantly reduced cardiac output, decreased stroke volume, and decreased forward pressure wave. But interestingly, females had no change in forward wave pressure. So you should see in these figures here, I can repeat that, the forward wave pressure, we saw a reduction in both sexes. Reflection magnitude was a little bit higher in women than men. And in forward wave pressure, we saw a significant reduction in males, but we saw no change in females. So in summary, so far what I've talked about, there are known sex differences in aortic blood pressure and wave reflections across the lifespan and in trained populations. There also seem to be sex differences in post-exercise hypotension. Both men and women, we would all agree, do experience this beneficial post-exercise hypotension. So they do reap the benefit of exercise on hemodynamics. But we see different ways of regulating. So sex differences are really important to examine because we don't know what this means, right? So if they regulate differently, if they have different responses, what does that mean long-term in their response to exercise? So as a reminder to those of us in the audience, sex differences are really important to examine because cardiovascular disease is the leading cause of death in both sexes. However, in females, it is higher than men across the lifespan. And it's really that population of 60 and older and women that we can focus on, but we want to get the middle-aged and younger populations before it's too late. And in 2014, the NIH actually rolled out a new policy requiring that sex and gender be included in research. So this is really a call to action that we need to do better. We need to have more research in sex differences because, as you see, there really isn't a lot out there. There's not a lot that we know, but we do know there is a difference. And now we see that more than 50% of NIH-funded studies currently include women, so that's great. And so hopefully in the next 5 to 10 years, we'll see more research out there giving us more insight into sex differences. So I'll leave it to you. Does sex matter? I would say yes, but I am biased as a sex differences physiologist, but it might also depend. So some of you out there that are looking at just the fact that blood pressure is reduced, you may not care how that happens, right? If Joe and I both exercise and blood pressure is reduced, that's great, right? But if we really want to know how that's occurring and what does that mean for overall risk, then we need to make sure that we are examining sex differences. So examining sex differences is a real need in physiology since there's a disparity in cardiovascular changes with age and disease. And it's particularly important in the wave separation analysis research because we really don't have a lot of data on the regulation of aortic blood pressure and exercise. I also want to ask the question of the importance of aging and disease populations. So for the sake of timing, I couldn't get into too much of aging and disease populations, but it's really important because how do we know if clinical treatments might be different, right? If women are regulating more vasodilation, which is a more preferential way of regulating in response to exercise, and men are increasing or decreasing their stroke volume, then at a young age, men have more cardiac work than women, but then what happens in menopause, right? So there's a lot to discuss here with regards to if we know mechanistically what's actually happening, what people respond to better, maybe we can change clinical treatments or exercise treatments to be more specific for different sexes, right? A lot of speculation, but I think I went last because it's more of a discussion piece to kind of think that we are missing this link in wave separations and aortic blood pressure.